All right, so we now are, this is session number 4 of these small group sessions. How's it been going? Okay? Yeah, so I want to say a few words before we get started, and that is just thinking through how you approach these papers. And each study design, you know, as you've been going through them, you notice there are these lists of questions, right, in your handouts. So with randomized controlled trial, it said something like, what was there randomization, and was there blinding, and was there concealment of randomization, those kinds of things. And then you get to another study design, and there's a different set of questions. Well, you see, when you read a paper, you don't read it like a book. Okay, you don't just start reading, and it's not like a novel that you just keep reading and reading. No, that takes way too long. Okay, what you need to do is to have that list of questions in your head and start scanning this paper. Start scanning the paper for the answers to the questions. So you have to learn those questions. And when I pick up a randomized trial, I have a new set of questions in my head that I'm approaching this paper with. And the other point is you have to know something about the anatomy of a paper. I mean, where do you go looking for the answer to that question or that question? And so say, well, I know where in a randomized trial, where to go looking for whether randomization was concealed or not, or whether there was blinding or not, or like that. So I have this question, and you search, you just scan the paper until you find the answer to the question. And oftentimes, you bump into another answer to another question while you're searching for this one. So those questions are all in your mind, and you just start scanning. And you're looking, you know, you look at a whole paragraph and you say, I'm sure that answer is somewhere in that paragraph because it's about where it should be. So you kind of look carefully, and then as soon as you say, was randomization concealed, you find, oh, there was a central telephone system, check, and move on to the next question. Dunk, 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 and then you can do it very efficiently. Okay, so that's one idea I want to just say up front. Another aspect is that when you are doing any evidence-based medicine, you need to do PICO, but where does PICO originate from is from the patient, right? So you need to discipline yourself to do it. I know it sounds like kindergarten, you know, PICO, and you know, you can make a little song about it or something, but you know, PICO emerges from the patient. Then when you write those words down, they become the source for your search, okay? Then you search, and then you find a relevant paper. And then when you're reading this, the first thing you do is to find PICO from the paper, okay? And then you try to match it and see, does this PICO from this paper match the PICO from my patient, okay? So those are a couple different ideas to help put a context around all that we're doing here, okay? So let me find this. So this prognosis unit is on acute pericarditis. And what we're going to do is to do a critical appraisal of a prognosis paper. And we have a rather lengthy scenario. How many of you have read the scenario already? Astaghfirullah. Nobody. Okay, well, hopefully we'll, I don't know how much time I want to spend on it. This particular one, I thought the last one was long, but no, this one is the long one. And so let's start then with this patient, okay? Can you see? You probably can't see here. Move this out of the way. Can somebody read it? Just read at least this first part here. And then what we want to do is to get into our mind PICO, okay? Now, this particular paper, PICO may be a little bit challenging, but we'll get to that in a minute. But just think about population, exposures, and comparison groups, and then outcomes. Okay? So someone read it, and anybody.
Mrs. Laundry is a 65-year-old immunosuppressed woman, chronic prednisone 15 mg QD, with a 6-year history of rheumatoid arthritis, admitted with onset of severe substernal chest pain radiating through her left shoulder upon awakening. Her emergency room evaluation revealed stuttering chest discomforts over the past 2 weeks. No recent flare of her rheumatoid disease, nor antecedent illness. And her chest pain was not positional. On examination, afebrile BP 100/60, heart rate 80, her lungs had diffused Velcro crackles in lower two-thirds field bilateral, consistent with her known pulmonary fibrosis. She had no cardiac murmur or rub, and no evidence for active cytokinitis. She had partial response to SL-nitro, something with nitro, and her ATG showed U2 ml ST elevation anteriorly. She was rushed into cardiac cath lab for emergent catheterization. It revealed no evidence for obstruction coronary artery disease.
Okay. So what are you thinking so far clinically, I mean, in this particular case? What comes, I mean, the coronary arteries are clear. What do you think?
Well, we have to build up a differential diagnosis for chest
Right.
pain regarding their
Right.
condition, and as long as coronary artery disease is excluded, you might think of a cardiac or pulmonary.
Right. Right. So let's just skip through this a little bit quickly. So she went to the ICU. She had diffuse ST elevations then, and then let's see. There's no evidence of bacterial infection. Did I skip the echo? Here it is. So the echocardiogram showed a small pericardial effusion. Okay, she had better pain relief with ibuprofen. Fine. So she's told now she has acute pericarditis. Doesn't seem that it's bacterial. Maybe related to a rheumatoid disease. Maybe a viral illness. And then she's asking, will it recur? Is this going to happen again? Because that chest pain was pretty frightening. Okay? And so you tell her, well, most of the time it resolves. And then she says, but is it going to happen again? And so you go to the UpToDate. How many of you use UpToDate? Do you have access to UpToDate? It's a useful tool. It's not necessarily an EBM tool, but there's a lot of good information there. And then they do have articles and things. And it says constrictive pericarditis may occur in about 1% of patients. You say, oh, that sounds good. Then, oops. And so let's see, but then you consult a Dynamed and you're immediately disheartened when you see recurrent pericarditis reported to occur in 8 to 80% of patients. You think there's a lot of sort of conflicting information here, so I need to do a search. So how do we begin to put PICO together in that clinical scenario? What's our main question here? So. Okay, so she's 65, she's immunocompromised, she has RA, she has chest pain, and let's say, and pericarditis. Okay? So, now, if you're going to search, we have to do this, right? PICO. So what is PICO for this question that we're asking, or this resident is asking? So what's the population? Okay, so you have to figure out how many of these things are clinically important when it comes to the question. Because you could put everything down. She's a woman, she's 65. I mean, you could put lots of things about the population. Well, let's think. What's our outcome that we're interested in? Let's start with that one. Recurrence, right? So recurrent pericarditis. So if our outcome is recurrent pericarditis, what do you think our population is? Right, okay, so pericarditis patients, that's our primary population. Now, we have to figure out, well, if this is our population, do we need, you see, when you're developing this, what you're actually doing is putting the demands on the paper you're trying to find. So you have to decide, do I want to restrict the paper to only pericarditis in immunosuppressed patients, or do I need to restrict it to pericarditis in rheumatoid arthritis patients, or in women, or in older, 65 is older, okay, older than me, okay? So you have to decide what to demand of the paper that you're going to apply to. So he's coming back to immunocompromised. So, well, what kind of exposures are we talking about here? Well, now this wouldn't be what's a good intervention. It's saying, am I going to have a recurrence or not? And so you could think of, what are my risk factors for getting? Okay, that's possible. So you could say, let's just put a general thing here, because this is, it's not as tight as some of the other questions you've developed, right? So about the therapy with clopidogrel or whatever. But here, let's say risk factors compared to no. And in this, there could be things like immunosuppression, or it could be various things. Okay, so now we have a setup of PICO. Okay. Now, our question, what is the type of this question? Is it a question of risk factors? Is it a question of prognosis? Okay, so we're looking at prognosis here. It's not a question of treatment or diagnosis or anything like that. So when you do this search, you're going to use words that are on this page, okay? And so what would happen, let's just say immunosuppressed, and then rheumatoid arthritis, for example. How do you choose what words to put into the search box? Like, what are you going to put in that box?
First, almost nothing, and then try to add.
Okay, so you could start with, now, so we have a number of words. We have pericarditis, we have immunosuppression and rheumatoid arthritis or risk factors, and we have recurrence of pericarditis, and we have prognosis. Which ones can give you the best kind of draw here on the papers that you're, and how do you do it? Okay, so what's that?
Prognosis of pericarditis.
Okay, okay, now what you did, you chose two words. You chose two words. You chose this one, and you chose this one out of all of this list. And the thing is this, what you do is, what I do, I should say, not what you do. What you could do is play a game. And you think to yourself, if I were writing this paper, if I did this study and I wrote this paper, what words in this list would have to be in the title? What words would have to be in the title? You couldn't write it without it in the title. So this one has to be in the title, right? And this one, well, could you write a paper without pericarditis in it? No. Could you write a paper on this topic without recurrence in it? So don't start with that one. Start with the ones that have to be in the title. Yeah, and I would say, so Ahsan, I mean, he was great. He said prognosis in pericarditis. So then I would choose these two, and I would say pericarditis, and then and prognosis. Now, if you did this, okay, pericarditis and this, how many papers would come out if you put this in like this, pericarditis and prognosis? So many papers, you would lose heart. So here's the thing, where is this actually searching? Where is it searching for these words? What's that?
Filters.
Well, okay, but you have to be really clear. Where are they actually searching? Where will they find these words?
No, titles.
In the entire paper. The entire paper. So do you think there are any papers out there that have the word prognosis anywhere in the paper, and they have the word pericarditis in the paper, and it has nothing to do with your topic? Absolutely. How many of you have done this and you just say, Mak Faida? I mean, you have 10,000 papers and none of them relate. How do you make them relate? How do you get a search strategy where they actually relate to your topic? Okay, go back to your thought experiment. If I were the author, what words would I put in the title? We said these two. So absolutely, you restrict it to the title. Okay, and you restrict this one to the title. You say, I want papers that have prognosis in the title, and I want papers that have pericarditis in the title. Now imagine those papers. What percent of those papers do you think would be relevant to your... They may or may not. There still could be papers with pericarditis and prognosis in them which don't answer your question. But don't you think the yield will be much, much better? Okay? So that is a strategy which can revolutionize your searching. Just restrict, say what words have to be in the title, and then restrict those words to the title. That's it. Okay? So now you do this, and look at the title here. Would this catch this paper? Yes, it would. So we get a paper. Yes. So we have this paper, and we say, well, what's the first thing you do when you look at a paper? Okay, yeah, that's true. But but again, it's not reading, it's thinking about your question. What's the first question that you want to ask about any paper? PICO. You started with PICO with the patient. You used PICO to search. And now we want to know what's PICO of this paper. So where do you go looking, again, knowing the anatomy of a paper, where do you go looking for PICO? Where's the first stop? Before the methodology. Before the methodology? Before the introduction? The title, very good. Yeah, the title. So here, let's just look at the title. Can you get PICO from this title?
Yes.
Okay, what's the outcome?
Prognosis. Good prognosis.
Good prognosis. Now, do they specify what the actual outcome events are here?
No.
They don't really. I mean, is it death? Is it recurrence? Is it infection? Is it whatever? We don't know, but we know there's some outcome out there that they're looking at. And do they have the population? Yeah, so now you see, we don't know if they're adults or children from the title, but there's a key word, a couple key words that will give you population. And that's, if you see in a title the word in, or the word among, or in this case the word for, that tells you, oh, everyone in here has that thing. So if you say blah, 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 in diabetics, what that means is that the population is everybody in the paper is diabetic, or among diabetics. In this case, prognosis for pericarditis. Oh, everyone in here has pericarditis. So can pericarditis be the exposure, or can it be the outcome? Only if it's recurrent pericarditis. You couldn't, if it were diabetes, could diabetes be the outcome? Well, there's a difference between diabetes and pericarditis. What's the difference?
This is a chronic.
Yeah, diabetes is a chronic disease. Once you have diabetes, your outcome isn't going to be diabetes. In pericarditis, you can have pericarditis as the population, but then also as the outcome, because it goes away and then you look for recurrence, like asthma exacerbations. In asthma patients, what's the risk factors, for example, for asthma exacerbation? Okay? All right, and then they say with and without myocardial involvement. What is myocardial involvement then here? Is it the population or the outcome? Yeah, they'll be looking at it kind of like an exposure. If you have myocardial involvement as opposed to no myocardial involvement. So I would frame this as, well, we don't know the outcome yet, so where's the next stop to look for PICO? Where's the next stop? Okay, yeah, you can look at the abstract, because the abstract gives you a lot of detail in a very short amount of time. So can anybody find what the outcome is from this abstract?
Prognosis of myopericarditis or perimyocarditis.
Okay, yeah, so that was the prognosis, but again, that doesn't give us the outcome, events. What are they actually looking for to say what the prognosis is? It's down in the methods toward the end of the methods and results part.
Conclusions, outcomes, not specified description.
Yeah, somebody said it.
Recurrence.
Yeah. So, well, what did they say above that line? No deaths were recorded, so they're looking at death as an outcome, okay. Any other ones? Normalization of left ventricular function. Recurrences, mainly as recurrent pericarditis, were the most common complication during follow-up. Okay, so you get an idea here that these outcomes that they're looking at are death, recurrence, yeah, normalization of LV function in those who had myocardial involvement. Okay? So do you now have a good sense of PICO in the paper? I think I have a fairly good sense of it. Who got into it? People with, and you can see here, people with acute pericarditis. And then myocardial involvement or not, and outcomes of death and recurrence. Okay? So that's your first stop when you're looking at a paper. Just quickly find PICO in here. Okay? So you know what this paper is about. Okay? Now we can start, if you want, looking at some of these questions. If we have here. So are the results valid? Actually, the thing is, I feel like sometimes this is getting a little ahead of things, whether they're valid or not, because I want to know what they did, right? So in a paper, where do you go looking to see what they did? The methodology. Now, it's always useful See, how do you think, and what kind of study is this? This is a cohort. How is a prospective study organized in the methods? What's the anatomy of the methods, and what do they deal with first?
Participants. Some.
Okay, so they start with the participants. And then what do they do? Inclusion, that's part of participants. That's describing who got into the study. Then what do they look at next? Characteristics, exposures, and comparisons. Yeah, methods of assessing the exposures and the comparison group. And then what's after that? Comparison, and then the outcome. So population, and then the exposures and comparisons, and then the outcome. Oh, did I hear that somewhere before? PICO. They organize this by PICO. Okay, so if you look, and then what's after outcome? What's the last thing in the methods? Statistical analysis. Look at how this is organized. Participants, diagnostic criteria. That's still part of participants, right? Look at the headings. Diagnostic workup. We're measuring things. We're measuring exposures and comparisons. And then treatment. We're also measuring what treatments they got. Clinical measurement and follow-up. And then statistical analysis. Do you see? It's the same thing for randomized controlled trials. PICO. They do the population, then the study design telling you about the randomization, what's the treatment that they got, and what was the control that they got. And then the follow-up, how was it measured, what's the outcome, how did they ascertain it, and then the statistical analysis. So once you know that structure, then you can know, well, when I want to know how they measured the outcome, oh, I know where to go. Right there. And how did they define the population? Oh, I know where to go, right there. So all these questions that are in your mind, you know where to go to get the answer. That's how it works. Okay? So let's kind of look here and see what they did. Let's just do an overview of what they did. And by the way, there are different ways of reading papers, right? Some people read the paper like this. Conclusions in the abstract. The outcome of myocardial inflammatory syndromes is good. Oh, okay, I read the paper. That's one approach, right? Another approach is to be really strong and read the abstract, right? Okay, that really takes a lot. And then, if they really want to be good, they read the introduction and the discussion, right? See, what we want you to do is to skip all that, read the methods, and read the results. And then you have your own discussion in your head. Okay? You come up with, if you see what they did, if you see what they found, that's really the zibda of the study. That's where you go to get the heart of it. The problem is, if you don't know how to approach it, you're going to end up doing those other approaches, right? Okay. So, let's just quickly look here. Let me see if I can get this up on the screen. So here are the methods. And what I would do here is, I want to know who got in here. Now this is a lot of reading, right? But you can kind of get the sense of it. Just look at it and say, okay, it was over 4 years. This word consecutive, that's a good word. It means they didn't skip. They didn't choose and cherry pick people that they wanted in there. That's an important word. And when you see consecutive in this kind of study or in a diagnostic test validation study, look for that word, because it means that they didn't select them out. Okay, so pericardial inflammatory syndromes, acute pericarditis, myopericarditis, and perimyocarditis. I had to do a double take on that when I first read the paper. going back to pathology, whatever, right? So what this means is myopericarditis is mainly pericarditis with a little bit of myo involvement, whereas perimyocarditis is myocarditis with some pericarditis involvement, okay? Okay, so, and this is a prospective study, so they're collecting patients with these issues, and what do? Okay, they're going to give you a diagnosis. How did they diagnose acute pericarditis? So you quickly look at it: chest pain, pericardial friction rub, widespread ST segment elevation, or PR depression, new or worsening pericardial effusion. Okay, so this sounds like a clinical definition to me, and then you have to ask yourself, do I agree with this definition? The only one I wouldn't is, no, they said at least two of the following. So, okay, I'm fine with that. And then a clinical diagnosis of myopericarditis, they describe that as being acute pericarditis with elevation of cardiac enzymes, but no depression without any new onset of focal LV dysfunction. Then perimyocarditis was all of that plus evidence of focal or diffuse myocardial involvement. Okay, so far so good. And then I kind of scan that, say, let's see. Myocardial inflammatory involvement was clinically suspected in atypical EKG changes. So some people got cardiac MRI when there was evidence on the echo that there was some wall dysfunction. Okay. Then what was the workup that was done? So everybody got a clinical evaluation, blood chemistries, so they did the CMR when myocardial inflammatory involvement was suspected, and then they have a diagnosis here of the severity, right? Mild, moderate, and severe pericardial effusion, okay? Cardiac tamponade definition, I'll probably skip over that because I'm sure it's a standard definition. Then coronary artery disease was excluded in patients with coronary risk factors. Okay, so you go down through. This is all sounding very standard clinical assessment of pericardial effusion, right? Then, histopathological confirmation was obtained with endomyocardial biopsy, but only on those that had severe LV dysfunction. In the study, following indications were considered for biopsy, subacute or acute symptoms of heart failure, etc. But it sounds like that didn't happen that often. Okay, there wasn't much of that. Then, how were these people treated? So you look at aspirin or NSAIDs. How were they treated? Aspirin or NSAIDs, usually ibuprofen was considered. Okay, then it says reducing, so this is some clinical things in terms of the dose and so forth, right? Corticosteroids were considered the second choice, fine. Colchicine was also optional, although I think more recently colchicine is, do you all use colchicine more now? I think it's becoming more. Okay, so do you see how to quickly run through this without spending a lot of time? Then, okay, so they did all these measures, and then what did they do for follow-up? So someone tell me, how did they do follow-up? Just quickly scan it and you tell me.
ECG.
Okay, so the ECG. Yeah.
Of 160 months.
Mm-hmm.
Yearly. Judgment testing at 6 months.
Mhm.
And
It-
then the events are recorded.
Yeah. So what, and the events they're looking for are recurrent pain, relapses, tamponade, residual LV dysfunction. So,
Cardiac tamponade, restrictive blood pressure,
yeah.
heart failure, and gender.
Okay. So now, you've gotten through the methods basically now. Now the question is, going back to our handout, which is this one. Now we can start asking these questions because we now know kind of what they did. So are the results valid? So let's look. Was the sample of patients representative based on what we read? What do you think? How do you get a representative sample of pericarditis patients? What would be... Okay, but did they pick them up when they had chest pain or pick them up when they had pericarditis diagnosed? They were already diagnosed, right? So they got them into the study already diagnosed. So what was the key word that helps you feel like, yes, this may be representative of all cases of consecutive, okay? Now, the other thing that you have to look at is where was this? This was in referral centers, okay? So these are referral centers. So do you think it's possible, like think about people with pericarditis, okay? Suppose someone is having chest pain. They go to the clinic. So when it comes to bias, what you have to do is just think through what happened. They're telling you what happened and you think through. So let's suppose someone with chest pain went to the clinic, which seems a little unlikely. You'd think they would usually go to the emergency room. But if they went to the clinic, what would the clinic do? Push them over to the ER. So now they're in the ER, and what will happen if they're having chest pain and ST elevations? They'll probably be, yeah, they'll be managed, and they'll probably go to the ICU and be ruled out for MI and do all of that, right? So now they're in the hospital, but now this turns out that these were referral centers, not primary, not sort of community hospitals, but referral centers, so more tertiary hospitals. Do you think that they might not get all the cases, or do you think they might get the more severe cases coming to them if they're a referral hospital? Maybe more severe cases. I don't know. I'm not sure. It depends. We'd have to know something a bit more about these hospitals. Do they have like a... Yeah. In other words, let's say it's in a community. Do they get, and whenever you're thinking of hospitalized patients, always think of the catchment area. Where are they getting patients from? So suppose there's a referral hospital. Do they, and they're in a city, do they take cases from the general population, right? Probably. They have an ER and there are people in the local population who will come. But if they also are a referral center, maybe they're more complicated patients may be coming from outside, from a community hospital being referred there. So you might get a mix of a little more severe cases in this particular place. Okay, it's possible. That's how you have to think about potential bias in this study. Okay, so, and since it's prognosis, what might we expect? We might expect that the prognosis in this particular group may be a little worse than all patients. Do you see what I'm saying? Maybe. We'd have to know something about these referral patterns and you know, how often does a community hospital refer a more complicated pericarditis case to that referral system. Okay? So that's the level at which you have to think about bias. You just imagine things happening. What could have gone wrong? What could have been different than you think? Okay? So that's how that works. All right? So I think it's reasonably representative, but might be sicker than we think. Might have more complicated patients than not. What would that do to the result? Would it bias the prognosis better or worse? It might make the prognosis look a little bit worse than.
Do you mean why there is a delay in the outcome or the prognosis of the cases? Is it because of this bias? That's what make some of the cases we reach the diagnosis faster than the others?
Not so much faster, it's just like if you're asking what the prognosis is, the disease is always on a spectrum. You have severe cases and mild cases. So when we say, is this cohort representative of all the cases of pericarditis, the mild, the moderate, and the severe, okay, then you say, well, maybe this hospital has more severe cases than everybody. What would be a way that they could deal with this problem? They could look at the prognosis in the mild cases, the moderate cases, and the severe cases, which I wish they did that, but they didn't do it actually in this paper. But that way they could say, look, okay, our hospital has more severe cases, but we're going to stratify by that, and therefore we'll separate out the severe cases and see what happens to them, and the mild cases and see what happens to them. So even if we have more severe cases, we can deal with that problem by just stratifying, right? So, but they didn't do that, unfortunately, which they could have. And if I had reviewed the paper, I would have said, do it. But I didn't review this paper. Okay, so you get that idea. So how representative are these patients of all patients? Then were the patients sufficiently homogeneous with respect to prognostic risk? Now, that question is sounding a bit more like a typical randomized trial or cohort study. So I'm not sure why that one is in on this paper, but because if you're looking at the exposed group and the unexposed group, then you want to see how close are they to each other. Do they have similar prognosis or not? And if not, did they do adjustment to see if that comparison is fair? Here we don't really have a comparison group except for one, which is what? We had myocardial involvement, right? That was our one sort of main exposure that we got from the paper, right, from the title. So actually, the answer to that question is if you are going to compare the follow-up, remember table 1 in a randomized trial? What's it doing? It's comparing the treated group to the untreated group. And what's down the side? The characteristics. So I'm going to get a little epidemiologic on you here. So if we have our exposure, which in a trial is an intervention, right? And we have our outcome. Then we have something down here called C. What are these? Potential confounders, right? What makes a confounder a confounder? It's something that is associated with the exposure, or this, and something that's associated with the outcome. Now, for this confounder to work, there has to be an association here, and there has to be an association there. And what that does, if they both are associated, if this is associated, both the exposure and the outcome, it can distort this relationship that you're seeing, right? So here's table 1. Let's just imagine, let's remember back to our randomized control trial. What was up here? Clopidogrel. And what was over here? Aspirin. So you have and then you had all these same types of things down the side. And when we looked at age in the clopidogrel group and in the aspirin group, what happened? Was the age the same or was it different?
It was the same.
It was the same. What about smoking? It was the same. What about previous DVT? The same. And you just look at that and say, mashallah, look, they're all the same. How did that happen? How did that happen? Where age was the same, gender was the same, diabetes was the same, everything was the same. Randomization made them all the same. So if age is the same in those two groups, is there an association between the treatment and age? Is there an association between age and the treatment if they're the same? No. So what happened to this association between age and the treatment? It's canceled. Can age be a confounder anymore? It can't. So randomization made this one the same. Now I want to step back now and look at this one. Anytime you look at a table, you say, how many variables are up here? How many variables are there?
3.
It feels like 3,
1.
or is it 1? How is it 1 variable? Why is it 1 variable? What would you name the variable if it was 1? Well, disease can be anything, but this one, pericarditis, myopericarditis, and perimyocarditis. Type of patient, type of pericarditis. 3 types of pericarditis, 1 variable with 3 levels or 3 types, right? So this is a variable up here. And how many variables are down here? Lots. So you tell me now, in the columns, which one of these 3 is in the column? Which one of these 3 is it the exposure, the outcome, or a confounder?
The exposure.
Okay, they're looking at pericarditis, myopericarditis, and perimyocarditis as an exposure. So they have this up at the top, and what's down along the side? The outcome or the confounders? Potential. So when you see a table, try to fit it into this triangle. Say, which one of these 3 relationships am I seeing here? 1, 2, or 3? 2. And so, what am I trying to say? If I'm going to compare, I'm going to compare pericarditis outcomes in this group to this group to this group. I need to know, could age be a confounder or not? So you tell me, can age be a confounder in the relationship between myocarditis and death? Or why? Why do you say that age can be a confounder?
I think so.
You know, you have to look at the table.
Because there is a difference.
Ahsan, that's it. Do you see, these people are older. These people are younger. And so therefore, if you're going to follow these people forward in time, they're older. They're dying more. They have more complications. Is it because of their age, or is it because of the pericarditis? That they have the pericarditis. Do you see? Is it a fair comparison if you just say what's the outcome in this group compared to this group if their ages are different? There's potential confounding going on here. What's really disappointing about this paper is they do nothing about it. Okay, they don't do any adjustment, they don't do anything. So I have to say I'm quite disappointed in the paper. We'll see as it comes through. Now, how about male, female? Is sex associated with, yeah, there's fewer men here and more men over here. Now, maybe male gender, I don't know if that's really associated with those outcomes, but okay. Then chest pain, most of them had it. Let's look at down here. What's anything interesting? Pericardial rub. Oh, I was interested in this one. Look, pericardial rub, pericarditis 24% and lower among the other. And I was thinking, how many people think, oh, I didn't hear a pericardial rub, so it must not be pericarditis, right? Like, this is telling us, no. If you don't hear it, it doesn't mean they don't have it, right? So interesting. That was kind of a clinical note on the side. I was like, oh, okay. So you can't say that they didn't have it if you didn't hear it, right? Okay. So, and that's one of those medical student problems, right? So, but you all are not there. Okay. So do you see how you look at this table? You're looking at this table to see, are there potential confounders here in my main exposure that I'm interested in the outcome? And I look at this and I say, yes, they're especially age. And then, you know, obviously these people are very different as well. You know, they have myocardial involvement and those people don't. But that's what we're trying to sort out. Okay? So, any questions on how you look at this table? And do you see the analogy between this table and table 1 in a randomized trial? It's asking the same questions, saying, is my intervention associated with all these confounders? And in a randomized trial, it should usually be no, 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 no. And the reason that is because of randomization, right? Then, let's go back to our questions and see how we're doing. Okay, so now, were patients sufficiently homogeneous with respect to prognostic risk? Yes or no, based on our discussion right now? I think I'd be hesitant to compare them because this group, the pericarditis group, is so much older than the other group. Okay. Now, was follow-up complete? Now, let's look at the paper. Do they say anything in this paper about follow-up? Okay, so where do you think you would find that information? Like what percent were followed or what percent were lost to follow-up? So here we have, yeah, well this one here, you see the clinical measures and follow-up? We read that already. There wasn't anything in there about it. So you're like scratching your head saying, okay, follow-up can sometimes be in the methods here. Sometimes you'll find it at the beginning of the results, or sometimes near the end of the results. So that's one which you have to kind of look around for. It jumps around from paper to paper. It's not always in the same place. So let's look here, results, clinical presentation, baseline features. I don't think it'll be in there. Patient management, no, I don't think it'll be in there. Oh, outcome and follow-up data. Now, it wasn't in the methods, so I would expect to find it here. Right? Does everybody follow what we're doing? We want to know what percent were lost to follow-up and how many people completed the study. So they say the median follow-up was 36 months. The range was from 6 to 66. Now, you see, if we go back to the very beginning of the methods, it says between January 2007 and December 2011. That's our study period. Now, at some point, you just have to stop the study, right? They stopped it in December 2011. So the problem is, what if they found somebody, if they enrolled somebody in 2010? They could only be followed for a year, or that they would be biased. You know, if for example, in a randomized trial, if you're assessing, did this person have a stroke? Remember from our clopidogrel study? Did this person have a stroke? And we're all sitting around the table looking at the medical record. And so if we look at it and we say, well, he was on clopidogrel, I don't think this was a stroke, right? So, and everybody said, no, it couldn't be. He was on clopidogrel, right? And then if you're all sitting around saying, well, was this a stroke? I don't think so, because I know he wasn't. He was on clopidogrel, so I don't think it was. You know, so there's this bias that can come in when you're assessing the outcome. That's why there's what protects or helps the blinding. I shouldn't know when I'm assessing the outcome. I shouldn't know whether they were on the medicine or not. So here, when they're doing the outcome assessment, there's no medication here to bias, like, oh, he was on I don't know, ibuprofen or not on ibuprofen or on whatever, colchicine. What, did he have pericarditis or not? I don't think that's not the question. They're just saying what happened to people. So there's nothing that the people assessing the outcome are invested in to make them be biased in one way or the other. Okay. All right. So now let's go to look at the results. What time do we have to finish? Is it 3:15?
Yes.
3:15. So this here is the result. These are the follow-up data. Now, for recurrence, what do you think this 31, 10, and 11 mean? What does it mean?
The percentage of the population that cases came up without cancer.
Okay. The percent of people in this group who developed the outcome. Okay, now, if you just look at it on its face like that, which group is having more events?
Pericarditis.
The pericarditis. Now, we know that these people are older, so I'm thinking, I wonder if that's because they're older. I don't know, because they didn't adjust. But it does seem it's happening more than in the other groups, right? And in a sense, that makes sense, right? I mean, if you have myocarditis with a little bit of pericardial effusion, you know, maybe the recurrence is not going to be as great. So clinically, it makes more sense that there would be more recurrence in the pericarditis than in the other. But, okay. Now, what about tamponade? How many percent have tamponade? A lot less, right? So much less here and 0 over here.
Yeah.
Okay, and then how about heart failure? Nothing. LV dysfunction. Do you expect this pattern? Here, here, and here? Do you expect that pattern?
No.
Yeah, why would you expect this pattern? 1%, 8%, 15%? Yeah, that makes sense. These are perimyocarditis. These are people with cardiac involvement there. Okay, and then death, 0, 0, 0. Okay. There is another problem with this one because they're kind of presenting it as an incidence or a risk. The problem here is that incidence, if you remember back, and it's my inner epidemiologist coming out. I just can't help it, but it upsets me what they did. You see, incidence, do you remember the difference between incidence and prevalence?
Yes.
Right? So no one needs me to tell you what prevalence is. But incidence is, you start with people without, let's say you have 100 people without the disease. You have to exclude the people with the disease here. So in this case, these are people without recurrence at the moment. Okay? And then you follow them forward in time, let's say it's 2 years. Right? And then at the end of 2 years, you say what percent of people who started developed the disease by the end of 2 years. That's risk. That's cumulative incidence. It's the same thing, cumulative incidence and risk. The problem here is that to really get a cumulative incidence, which is a percentage, you have to follow everybody for the 2 years. Was everybody followed for the same amount of time? No, they weren't. So now, people were followed for different amounts of time, right? Like that. And so, and some of them got it, and some of them didn't. Some of them had an outcome, and some of them didn't have an outcome. So now, the problem here is, instead of back here, getting a percentage, which is the number, this is calculated as the number of new cases divided by the total number at risk at the beginning, right? At the beginning. If you don't have everyone follow the same amount of time, you still put in the numerator number of events, the number of new events, divided by what? Do you remember? To get a rate. You need to get a rate. So you put this person time. So if this person was followed for 1 year, this person for 5 years, this person for 3 years, this person for 4 years, this person for 6 years. And there were 2 events. So you would put 2 events divided by 6, 9, 13, 9 divided by 19, and that equals what? About 22%, okay? Or 0.22. And what that means is if I follow 100 people for a year, 22 of them will get the disease, will get the outcome. Okay, so this is a quick simulation of how you would do it. It'd be very easy for them to do it. Did they do it? No. Now this is the fourth thing I'm really frustrated about this paper by. Because they're presenting this as if it's a percentage, which is a risk. This is not a risk. I don't know how much person time. Some people went there for 6 months, some people for 6 years, or 66 months. So I wish that they would have put rates here instead of percentages, but they didn't. Okay? So I'm getting a sense here that, well, what do you think? Do you think that pericarditis recurrence is fairly common? It's fairly common in the pericarditis group? Well, yeah, I mean, over this period of follow-up, it's about 30% of people who started got it, but I don't have a good sense of when it's occurring or how long it takes to occur. It's just 30%. And we also don't know about the losses to follow-up, but let's say it's there. You know, we have some sense that it's happening quite a bit, right? If 30% over 5 years had it happen. Now, they do something which is helpful. They give you this thing, which is called, what's that thing called? This is a Kaplan-Meier curve, okay?
Slope.
What's that?
Sloping down.
It's not a slope. It's there where these are stair steps, events are happening. Now, which one is happening more? The dark one is pericarditis, myopericarditis, and perimyocarditis. This gives you the time to event type data that I was hoping to see there. Okay? So, because this tells you when is it happening. Is it happening early? Is it happening late? So, what do you think about the recurrence in the pericarditis group? When is it happening early or late? It's happening fairly early. These others, the myopericarditis and the perimyocarditis, they're kind of happening a little bit over time, more extended. Okay, so now this makes me happy. Okay, shall I forgive them for all those 4 other things, or just forgive them for one of them?
One.
Because they did one good thing here. Okay. Do you see what I'm saying? So now, here you can see they're losing people a lot. But that could be that they're enrolling them later toward December of 2017, you know, and so they were followed for a short amount of time. But anyway, do you see here? So this tells us in a cohort study, it's always nice to see a Kaplan-Meier curve. That's called a Kaplan-Meier curve. You can tell it's a Kaplan-Meier curve if there are stair steps. What's happening at every step?
Event.
An event. So here you have time, here you have people, and the stair steps are events. And this is the percentage of people left without an event. So at the end of 1 year, what percent of people are left without an event? About 70. Right? So there, that's about, and then it stays pretty stable. So 30% of the people had an event within the first year in this group. Okay. Now that I do understand. Okay. So there's another thing. Whenever you see an estimate, like 32%, right? I always want to know the confidence interval. And the problem is, they didn't give any confidence intervals, did they? Let's look. The other thing is they could do relative risks here too, but they didn't. Up here, this 31%, I would like to know the confidence interval. Now, let's have a discussion about confidence intervals. What's the big deal about a confidence interval? I mean, isn't this 30%, 31 or 32%, isn't that really what I want to know? When you see an estimate and a confidence interval, what does it mean?
It means if you.
What's that?
The study is reproducible.
I'm sorry, but start with you and then you. Yeah, go ahead.
If you repeat the study, the results are reproducible within the range.
Okay, you're getting at a statistical point of view. The biostatisticians will love you. But that doesn't help me that much. And I'll show you what I mean. What were you saying?
It tells us what was the sample size and so quality of the study.
Okay, so it has something to do with sample size, because the bigger the sample size, what happens to the confidence interval? It narrows. So let's suppose this is 31.8%, right? Let's suppose it went from 26% to 36%. What is this talking about? What is this one talking about? Well, it's the percentage of people who got pericarditis, but who? Who among who? People in the study.
Yeah.
What is this talking about?
Very popular. The population, the general population.
Yes. So do you think if this study found 32%, and let's say it's not biased and there's no problem with it, if it said that, do you think, you say, where did these people come from? They came from a general population in Italy.
Yeah.
There's this target population out there, right? And do you think they can study everyone in the population? No, they got a sample of people and got them over here. And so what this is talking about is the target population, and let's call it the truth. Okay? This is the truth, the range of values that the truth could be with 95% confidence. So now, with all due respect to the statisticians, they say it's absolutely true. If I did this study 100 times, the estimate would fall within this range 95% of the time. Does that make sense to anybody? Because you're not doing it 100 times, and I don't know what that means. I can't put my brain around it. But if I say, I am 95% confident that the true recurrence rate in the target population that I'm interested in knowing is somewhere between here. I'm not 100% sure of that, but I'm 95% sure that it's somewhere in between here. Does that make sense? So when you see an estimate and a confidence interval, there's some things to think about. You say, this is still the best estimate, but the truth could be, with 95% confidence, somewhere in between here and there. And then, the next step, there's more. Do you think this is a wide confidence interval or a narrow confidence interval?
26 now.
26 to 36.
Quite. Oh.
Narrow. How do you tell? There's a little trick that you can do to tell whether it's wide or narrow. Because if it's, let's say, is it narrow enough for confident estimates?
Yes.
Okay? So the way that you do this is you say, well, what if the truth were 36? What would you tell your patient, this lady, if the truth were 36?
If the decision changes between the upper and the lower.
Yeah. What would you tell her here if it were 36? It happens pretty frequently.
Yeah,
What would you tell her if it were 26?
the same.
Yes.
About the same. It happens pretty frequently. Now, 26 or 36, but the general thing, it's in the general same ballpark. But what would you say if it went from 5 to 50?
This is a
That's why. Because at the upper end, I would say this happens all the time. And this one, very rare. So now, at the upper end and lower end, I have two different inferences coming out. If the inference or the thing that you tell the patient is different at either end, do you think your confidence in this number is lower or higher?
lower.
It's lower confidence. You have less confidence. That's why they're called confidence intervals. I'm confident, 95% confident that the truth is in this range. Well, if the range of values, upper and lower end, is different inference, then we have a problem. Remember this one? 0.70, 0.59 to 0.86. Remember clopidogrel and stroke in the first 90 days? Relative risk reduction of 30%. So you say, here's how you, now let's look at associations, because this is just a prevalence, or not a prevalence, but a percentage. This is a confidence interval on an association. So you say, how big is the association? What's the magnitude? Big. Big clinical effect. How confident am I on this number? Look at this. What would I tell them? Should they take clopidogrel if this were true?
Yes.
Yes. Should they take clopidogrel if this were true? Yeah. I mean, 14% relative risk reduction in stroke. Stroke is a bad outcome, so yeah, I think, so I might not be quite as strong here as here. It could be nice to be a little narrow, but do you see how that is, this is narrow enough to say I'm fairly confident about this, okay? Now, is this statistically significant? Is the p-value significant on this one? Do you remember how to tell? If the value of no association for a relative risk is what? 1. If 1 is outside, it's statistically significant. So is 1 outside? Yes, so it is statistically significant. Now let's suppose that it was 0.4 to 0.99. Is it statistically significant?
Yes.
Yes. Do you have as much confidence
No.
anymore? I'm less confident because it could do a lot of benefit or it might do nothing. But, okay, now what about this? If it went from 0.4 to 1.01?
Not significant.
Not significant. So should we throw the study out?
No.
It does nothing, it's not significant. So beware of just looking at the p-value. information here than the p-value. Let's back up. This is 0.7. Big effect. Confidence interval. I think it's wide, because at this end there could be really big, the truth could be a very big effect. The truth could be nothing. It's not statistically significant. Would you give it?
Yes,
Why? It's not significant.
but the effect is fine.
Well, you have to look at the whole thing. Most of these values here are showing value of benefit. Some of them show no benefit or very little benefit. Do you see how you can use these confidence intervals to give you more information than just the p-value? The p-value, see, in this case, the drug representatives will be waiving the p-value. It's statistically significant, you should use it. What, would you use it here? Would you use it in this case?
Yes.
What would you tell the patient, though? What would you tell the patient here?
Some people would.
What's that?
In some people would like it.
Well, it's not necessarily in some people. It's that we think it probably works, but we're not 100% sure.
Yeah.
There's still a chance it may do nothing.
Mm.
But, you know, clopidogrel is pretty cheap. Not that expensive. And we saw that there's some risk in minor bleeding, but no risk in major bleeding. Would you do it? You see? And would you do it with this? Even if it's statistically not significant. If this was all the information I had, I would say, and it reduces risk of stroke, and this is a big risk, I'd say, well, the truth could be major improvements, but I'm not sure. I'm not sure about it, but I probably would do it on the basis of it, even if the p-value wasn't statistically significant. I know I'm treading on a little bit of, thin ice, but the p-value is just an arbitrary number, 0.05. You know, if it's 0.049 and 0.051, is there really any difference? No, step back. How big is the effect? How confident am I in it? Oh, and then is it statistically significant? Biostatisticians will kill me for that, but that's the way I think about it, okay? So let me do one more. I know we're about done. What if it went from 0.1 to 2.9? What do you think about that one?
This is a wide.
You think it's wide? It's not
No,
wide.
no, no, no.
It's not wide. It's wide. See, every group I do this wide thing. It's wide. Now you have a whole different situation. Here you have tremendous benefit. Here you have tremendous harm. And it's 0.7. What would you do with this paper? Throw it in the trash. This one is no good. You have nothing, you cannot make any inference from this. Because you have the truth could be big benefit, the truth could be big harm. So you can't say anything about it. That's how you use the confidence intervals. So when you're looking at the relative risk, look at the magnitude of the association, look at the width of the confidence interval, and then look at the p-value. Okay? I think we'll stop there, but hope that you got it.